webinar. It is 3D, so we're going to go ahead and get started. We want to welcome you to addressing the special cause increase in pediatric CLABSIs. We're going to start off with some logistics today. It looks like everyone is on the telephone and didn't have issues with that, but if you do, please, there's a question box off to the right side of your screen that you can enter a question in there and we can help you behind the scenes. And there's also an audio box that you can click on. If you are on mic and speaker, just click on the telephone option and just follow the prompts. Here are our CLABSI co-leaders. We have Mike Gutzeit, who's on the phone with us today from Children of Wisconsin, and Holly O'Brien, who was unable to join us, is from Children's of Wisconsin as well. Jeff Horde from Akron Children's, and Margie McKeskey from Children's of Alabama. Here are our objectives for today. We want to understand the pediatric CLABSIs. We want to understand the root cause, testing theory, and the method to verify suspected cause, and learn from SPS experience in responding to special cause within pediatric CLABSIs. And with that, I'm going to hand it off to the project manager here at SPS, Emily Ayler.
Great, thanks so much, Erin. So next slide, please. So this is just a map of all of the hospitals within our network, the Children's Hospital Solutions for Patient Safety. Next slide. And our mission, as we start every meeting that we have, is working together to eliminate serious harm across all children's hospitals. Next slide. And our goals for the network, by the end of 2016, we hope to see a 40% reduction in the hospital-acquired conditions, or HACs, a 10% reduction in readmissions, and then unique to our hospital engagement network, we have the 25% reduction in the serious safety event rate. So next slide. And with that, I'll turn it over to Dr. Mike Gutzeit.
Thanks, Emily. This is Mike Gutzeit from Children's Hospital of Wisconsin in Milwaukee. And just to follow up and enhance what Emily stated, I'm really thankful that you're all on the call today. CLABSI, central line associated bloodstream infection, is likely one of the areas where you've invested significant resources over a number of years. But I'm guessing, like many of our hospitals, we continue to struggle with getting a significant reduction in the number of hospital-acquired conditions or events related to CLABSI. I've been very fortunate to be part of the Solutions for Patient Safety Network, which now consists of nearly 100 hospitals, 100 children's hospitals, focused on reducing harm in kids. And one of the concepts that SPS is really invested in is it's about all teach and all learn. Every hospital has something to teach, and every hospital has something to learn. And I'm hoping this webinar will be no different. As Margie and Jeff and I share some of our experience around CLABSI, we're hoping that you'll provide us some insights that may be helpful for all of us, and we may all benefit to reduce harm in kids. So with that, why don't we go to the next slide, please? So I'd like you to think for a minute of all the different hospital-acquired conditions, things like pressure ulcers, catheter-associated urinary tract infections, and CLABSI. And let's roll in some of the costs associated with those when these infections occur in our organizations. So you can see as they roll in here that it can get quite costly. And if you look at the topic that we'll be discussing today, central line associated bloodstream infections, we see a cost on average of about $35,000. So that's real dollars. Those are real dollars that affect kids, that affect their families, and affect the organizations in which they occur. And really what we're trying to do is think about that cost, but it's also the harm that occurs, and that's even more important than the cost, is how it causes harm and even death in some cases. So let's go on to the next slide. CLABSIs are unique for children, and I want to emphasize that they are not unique in their occurrence in children, obviously, but there are unique circumstances and some causal factors that are really relevant to pediatrics and may not necessarily play out in other areas. We know that kids are not just little adults. You've heard that cliche quite a bit, but I wanted to stress some of the reasons why that is true. As you can imagine, we treat children in pediatrics with an age diversity and a size diversity that can be from birth or pre-birth all the way up through adulthood. And so that's quite a wide range of developmental stages and ages that we're treating. We know that there are challenges with the immune function. Even in young, healthy children, sometimes there are challenges with immune function, but certainly many of the care of our chronic patients are ones that involve altering their immune function in some way, thereby decreasing their natural resistance to infection and increasing their susceptibility to infection. And we also have some concerns about using the typical things that we would use to reduce infection because of potential to sensitive skin. Children's skin is more sensitive in many cases than adult, more mature skin. We have variability in home care standards, and this can be a real issue because there are oftentimes difficulties finding the competencies in home care to provide special care for kids given their age and given some of the unique characteristics that they have in the home. And we also know that we need to be focusing on the maintenance elements of the central line associated bloodstream infection process as opposed necessarily to the insertion. We need to pay attention to the insertion, but most of the issues that arise are a result of maintenance. And finally, let's face it, kids are kids, right? I mean, they're constantly in motion. They aren't necessarily as concerned about hygiene as we are, and they're inquisitive. We have lots of interesting stories about what kids do with lines and how they manage and manipulate them. And just when we think we've got a way to prevent that from happening, kids find a way to outsmart us. So these are certainly unique factors that we need to be thinking about. If we could go on to the next slide, please. If we define what the hospital-acquired condition CLABSI is in terms of the problems that we face in pediatrics, I mentioned some of the unique circumstances on the past slide, but on this slide I'd really like to talk about a couple of things here. We deal with lots of different sizes of catheters. You can imagine that you can't apply the same size catheter to a micropreemie weighing 750 grams that you can to an adult-sized patient. So there's a lot of different sizes in between that we need to be concerned about. We also know that catheters, central line catheters, often lie in close proximity to other things like tracheostomies, gastrostomy tubes, and other ostomies. Because of the thinner vasculature of children, there's a higher potential for extravasation through that vasculature. For example, in neonates, the cell lining of the vasculature may be no more than 1 or 2 cells thick. So that creates quite a potential for extravasation. And also challenges with peripheral IV access. We may need to use central lines more commonly in children because the conduits from the peripheral IV sites are not quite as big or as accessible as they would need to be for delivery of the therapies. And finally, there's a much greater potential for line migration. Again, in the example of a neonate, just a simple matter of a neonate turning a head or lifting an arm up may move a line a centimeter or two, which could make a huge difference in terms of where it's located and the potential for complications related to that. Let's go ahead and move on to the next slide. I wanted to talk for just a minute about high reliability and our prevention bundle. So when we talk about prevention bundles, we're talking about groups of things that when put together have been shown to have a higher likelihood of reducing harm or reducing infection. And one of the things that we base this on is high reliability and using high reliability principles to utilize prevention bundles. You're likely aware of high reliability and the 5 principles associated with high reliability. And the Solutions for Patient Safety hospitals have really focused on high reliability as a means to incorporate bundles and other efforts to reduce harm hardwired into organizations. And there are 2 concepts I really wanted to use today to talk about our high reliability principles. The first is a sensitivity to operations, and that means really focusing on paying attention to what's going on the front line, realizing that that's where the care is delivered and that's where we need to really focus our efforts and listen to what's going on there. And the second principle that I really wanted to emphasize was a deference to expertise. And we all know that we treat very complex conditions. Medicine gets more and more complex as the years roll by, and we know that the children, especially who have relatively straightforward conditions, are usually cared for in an outpatient setting. And more we're doing things in the outpatient setting that previously was done in the hospital or even in intensive care settings. And because of that complexity, we really need to defer to expertise, which means focusing on expertise around the issue, not on the hierarchy or rigid organizational structure to solve and create solutions for problems. And this is the way that we get to better reduction of error in complex environments. So let's go on to the next slide. One of the ways that we focus our efforts and really prioritize what we need to do, if you consider the landscape of what the potential opportunities might be, is to develop key driver diagrams. And while this is a very busy slide, I wanted to really focus your attention on a couple of elements for this key driver diagram. And this was updated just recently, and we look at this periodically to make sure that we're focusing on the right things. So a key driver diagram really starts with a SMART aim. And the acronym SMART, because in medicine we can never have too many acronyms, the acronym SMART really stands for specific, measurable, achievable, relevant, and time-bound. So that's what the SMART acronym stands for. And you can see our SMART aim is to reduce CLABSI by 40%. As Emily mentioned earlier, that's one of our goals. And then I just wanted to focus also on the key drivers because I think that's very helpful. You can conceptualize putting things into buckets and then focusing on those buckets and pulling out the elements that you think are most important in those buckets to really drive where the work is and focus your efforts. Because if we try to tackle this problem universally without much direction, it's doomed to not succeeding. So we really think that the emphasis for our key drivers are increasing our reliability to a maintenance prevention bundle. That means getting to greater than 90% every time with our maintenance prevention bundle, and that would be every hospital. That's also important in the insertion prevention bundle. We know that accessibility is an issue with CLABSI, and making sure we have the proper supplies and the proper way and methodology to access lines is important. One of the things that has really helped all of us as a network is the transparency of data. And again, we are learning organizations, and all of us want to learn, all of us want to do better, and data drives it. Data wins the day. So the more that we can be transparent with each other, not in a way of finding fault, but rather in a way of finding opportunity, this is very, very helpful. I mentioned high reliability methodology, and all of our hospitals are committed to utilizing and incorporating high reliability principles. And then the clean patient environment is one that has come up quite a bit recently, and we'll be talking about that in just a minute or two. But it really respects the fact that there are lots of things that can happen in healthcare environments and lots of nasty bugs and germs that are around, so we need to make sure we're paying close attention to that. So let's go ahead and move on to the next slide. Our focus for this coming year is really around these three elements that you see on the slide. It's working on our prevention bundle reliability. As I mentioned earlier, our goal is to get to 90%. We struggle with that. As an organization, as a network, as an organization individually, and as a network collectively, we struggle with getting to reliability sometimes. So we know that opportunity exists to improve this. We also know that we need to measure what we're doing accurately, because sometimes we can get to 90% and realize that maybe we're not actually performing at 90%. We know that there's a special need for focus on our hematology-oncology patients, again, getting back to immune suppression and its role in central line infections, and the special causes or the special circumstances around hematology-oncology patients like mucosal barrier injury infections is important. And then environmental contamination. And here are the three things that we're trying to focus on, or three of the areas that we're trying to focus on, is daily linen changes, things like terminal cleaning of rooms, and then cleaning all surfaces, looking at all surfaces that might pose a potential for infection or the transmission of infection. So let's go ahead and move on to the next slide. It's a pretty simple concept when it comes down to how we can improve. We know that, and this has been proven, we have data to show this, and organization after organization has shown us, demonstrated that if we can increase our process reliability, we will improve our outcomes by decreasing the number of events, and we can do that by focusing on standardization or shifting to a process where we have these concepts structured in such a way that we know that the evidence supports these standardized elements, and we can all use those standardized elements to the benefit of our patients to reduce the number of events. So I'm going to move on to the next slide. Here's what I mean by standardization. So if we think about the prevention bundle, we've selected terminology and we've looked to our clinical steering team at Solutions for Patient Safety to help us become familiar with what things we need to be focusing on. And as we've gained more and more insight and evidence and more experience with the network over the past many years, several years now, we know that there are certain elements that we are utilizing that are standard elements, and these are the elements that have the strongest evidence around them. And we know that if we utilize these effectively, we measure them appropriately, and we have them in place and we are doing them, that we will benefit from them and they will create a significant decrease in patient harm. And so our requirement is that if you're an SPS hospital, that you should implement and measure the reliability of the standard elements. We also know that there are recommended elements that may not yet hold the same level of proof, as it were, or level of degree of expertise, but we know that they are showing us in preliminary data and in expert opinion that they probably are likely to improve care. And so we strongly recommend that the SPS hospitals consider implementing these. So the standard element, the recommended elements. Let's go ahead and move on to the next slide. And I'm going to just spend a brief moment on this. This is our maintenance bundle, and you can see here laid out the 4 standard elements and then the recommended elements below. One thing I would point out here is that when we try to implement bundles, we try to keep them as simple as possible. You can imagine this one doesn't look very simple, and we know that the CLABSI maintenance bundle is one of the most complex because there are so many steps and so many multiple layers of it, and therein lies part of the difficulty in maintaining a high level of reliability to the bundle. So we have lots of different discussion points around how we can get better at this and how we can better understand to be the best that we can. Let's go ahead and move on to the next slide. I wanted to show you just some data. So you can see here, this is some data from our SPS network, from the Solution for Patient Safety Network, and this is our reliability around the insertion bundle. Just to ground you in what you want to see, the green dotted line, what you're seeing on the slide, I should say, the green dotted line is the 90% reliability. That's our goal. Our center line is how we're actually performing, and the SPS reliability is the month-to-month variation that you see. So good news here, our center line is above our goal line. If we move to our maintenance bundle, which would be on the next slide, you can see that we have some work to do. And remember earlier I mentioned that we've got some opportunities, so our goal again is 90%, just as with the insertion bundle. Our center line, you can see, is not quite there yet, and our month-to-month variation, we're still below that 90% desired goal. So again, there lies some opportunity. Sometimes just looking at the basics is really what we need to be focusing on. Let me go on to the next slide, please. I think with this, at this point, I'm going to hand off the webinar to my esteemed colleague, Margie McCaskey from Children's of Alabama. Margie, you ready?
I am. Thank you, Mike. So that was perfect. To just think back to the last slide Mike showed you and the reliability with the maintenance bundle. If we go on to the next slide. So this is what our outcomes data looks like on a monthly basis. The yellow line in the middle is the center line for the network. So all of the hospitals send in their data, and you can see from, if you can read this small print, close to 90 hospitals are submitting data every month. Upwards of 13 to 14,000 line days are submitted in anywhere from 140 to 250 CLABSI events. If you look at that lowest point on the far right side of this scale, that is December of 2014. And then we had a spike. And if you think back to the maintenance bundle, you can lay these together and see the reliability maybe went down a little bit. We were a little concerned in January. And as the months went by in 2015, we all started to look at it and say, what is going on? We were still within our control limits, but it was clear that something was happening in the network. The rate was going up, and it all came together, culminated in June, July, and August when we hit event rates that were above our upper control limit. We had special cause, and that was really a red flag. For all of our friends at SPS that look at this on a daily basis, it was bells and whistles and, uh-oh, what are we going to do? Something is going on that needed to be addressed. So go on to the next slide, please. So we can't do anything without doing it in a process because we're dedicated to high reliability and looking at things in a very organized, systematic way. I am not going to read you this slide. It was very involved. It's very incremental stepped process to look at why did we have special cause. Looking back at those high reliability principles that Mike spoke of, we didn't want to simplify our interpretation of what was going on. We really wanted to get down to the root cause of the matter if we could. We were committed to being resilient and bouncing back from this and getting past it, learning from it, and bringing the rate back down, first to our current baseline and then going down from there. Our ultimate goal is still that 40% reduction over the 2-year period, and we've got some work to do now that we've had this special cause. And then again, having deference to expertise. We wanted the hospitals who had seen special cause on their graphs in their outcomes tell us what was going on in their hospital. Was there something that was driving the network special cause? So we put together a very detailed survey and sent it to 26 of our hospitals who had seen at least 1 month of special cause in their outcomes run charts. And thankfully, they were very happy and very willing to give us some information back. It was extensive. We asked about products and environment and staffing and electronic documentation, and was there anything going on in their hospitals or anything they wanted to tell us. We looked at organisms. Was there something different across the country that we didn't realize? All of this information came together, and then we started through it and started making comparisons to what was happening in the hospital, where was their increase in rate, and really trying to find some correlation. You can go on to the next slide, guys. Thank you. So these were some of the initial findings that we found during this period. We pulled people together at the learning session in the fall to talk about, what's going on in your hospital? Is there anything you want to share? Several things came up multiple times. Passive disinfectant caps, people were putting them on, they were taking them off. It was changing workflow. It was changing the way people were holding the line or thinking about cleaning the line. The way tubing is set up, there were hospitals reporting problems with tubing, wondering was it a product thing? Again, was it workflow? Many of the issues that arose really came back to, is it interrupting the way you are executing the maintenance bundle? And that really became a focus with us because those are questions that couldn't really be answered in the survey. We went back and talked to some hospitals, actually did a deeper dive with them to see did their changes impact what they were doing in their maintenance bundle. The Z-Flow pillows were referenced by a couple of hospitals. It's not necessarily the product, but again, how those pillows were being used and how they were being cleaned on a daily basis. So that product really became an environment issue and made us look at, were we cleaning the bed space, the patient space, and the patient as appropriately as we could have been. We looked at changing staff workflows. Many hospitals reported they had onboarding of new staff. I know they wanted to say we had this influx of new people, and maybe that's why our compliance was down or our infections were up. Realistically, hospitals have staff in and out all of the time, and we really couldn't find a good correlation between your staffing and your infections that would impact the network. All sorts of compliance with changes in dress codes and the addition of everyone seems to have a Fitbit now around their wrist, and was that impacting hand hygiene? Again, Mike mentioned keeping the linens clean. We had hospitals who said they had been changing the linen daily. They went to a 3 times a week or every other day, and then they saw an increase. Maybe that was it, or they knew they were supposed to be cleaning the beds or switching out the beds, but they they were so busy and they had so many patients in the beds that they didn't have extra to switch out. And then competencies in staff. When you're, it's not just line maintenance. Was it new products and new procedures in environmental services that maybe impacted the way areas were being cleaned? Were we truly following the bundle elements? And I can't stress enough that we firmly believe that this all goes back to, are we truly reliable with our bundle elements and making sure that we're doing exactly what we're supposed to be doing every single time we do it. And then that the special populations, there were hospitals that mentioned, you know, we have short gut kids with translocation, we have hem-onc kids that are having MBIs. The NICU population we know is unique in their skin issues and their moving the babies around issues, and then oncology as well. Those changes in the protocol that maybe was resulting in these patients being a little bit sicker than they had been, and are there things that are unique to that population that we really need to address? So one more slide. Again, this looks like the key driver diagram. We really wrote it in a way of, our goal was to really identify and verify and mitigate the root cause, if we could, for the CLABSI special cause events that affected the hospitals in 2015. And the suggested causes in the middle were the things we pulled out of the survey and through talking with our colleagues across the network that we felt needed some attention. Were there changes in the 2015 NHSN definition that impacted the number of infections we saw? Were there changes in organisms that we weren't aware of that we needed to investigate? Was there a change in product or device that collectively across the network people were using and running into problems with? And then this bundle process execution, how reliable is it? So, and then finally the change in patient population. The ones in yellow are the ones we are currently have people across the network interested in, engaged, and working on. So our methods to verify that suspected cause, we look at, we tried very diligently to quantify the definition changes and the impact that it had. And there were some infections in 2015 that would not have met CLABSI definition if it had been 2014. So we knew there was a rise in some of the numbers, and maybe not enough to have special cause, but we certainly would have had an increase in rate. So we're not discounting the definition change, but it's a definition change and we have to live with it. The CDC has worked with the SPS hospitals to look at the organisms. They are currently looking at that to see were there trends in what the organisms were. This interesting work that we have network hospitals who are willing to share their information. They already report to NHSN, it was already there, and so they gave permission for the CDC to look in more depth at that information. We have a work group, a focus group coming on board to look at products. Holly O'Brien in Wisconsin will be looking at, leading that group and looking at specifics, very specific questions to the network hospitals. What do you use? What product? When did you start using it? How do you use it? All of those things to try to discern if there's anything in common that we may be able to share with across the network, things to watch out for or things to recommend in the long run. And then finally, looking at the bundle process, we will have another work group looking at doing some real-time observations, being very, very explicit with what are we watching for, and be very prescriptive in the way we audit our maintenance bundle. We're going to ask some of our network hospitals to try this, to do some PDSA testing to see does the tool work. And if so, if we can get better results with our reliability measurement. Some of the things our hospitals struggle with is we don't know how to measure it. And so this year's goal is to get everyone on board measuring their reliability, getting us some really good solid data so we can then look at we know, or we believe, that as the process reliability goes up, our outcomes will go down. So that's our focus this year, is to put a lot of effort into that. And we collectively as a group decided that the change in patient population was so unique across the board that we weren't going to pursue that, with the exception of the HEMONC group right now. We are pulling together a HEMONC focus group to look at, beyond the bundle, is there anything else that they need to do for their patient population, because we know a large number of our CLABSI events occur in the HEMONC population, and what can we do specific to them that we don't necessarily need to do in the rest of the pediatric population, but that will drive our infection rates down for them. So with that, I'm going to turn this over to Jeff from Akron Children's Hospital to wrap us up.
Thank you, Margie. I am new to the SPS CLABSI leadership group. I joined about 2.5, 3 months ago, and I previously was one of the faculty members since about 2009 with the Children's Hospital Association Childhood Cancer and Blood Disorders Network, which has been focused on reducing CLABSI specifically in the HEMONC population, first in the inpatient group, and then it is later expanded into the ambulatory group. So in an effort to consolidate and to pull the two groups together, the inpatient work that has previously been done through the CHA HEMONC group is going to transition over into the SPS work, and that is part of what will create, as Margie alluded to, the Hematology Oncology Special Interest Group. So that's my charge in helping pull some of that together. So now that we've gone through the special cause analysis and have some input from the hospitals about what might have contributed to their increased rates, what are we going to do about that? So next slide, please. So some of these things Margie's already mentioned, but we're going to investigate them even further in the coming year as we focus on really bringing down the CLABSI rate. So some of the issues is, again, around product and devices, and that will be headed up by Holly O'Brien. Some of the things that's mentioned, it's not all inclusive, would be the use of alcohol caps. We've kind of heard stories in all directions, from people using them more to some people stopping using them, some studies that are going on around them, so we need to investigate that further. The use of different flush syringes and types, some that are pre-drawn up and packaged versus others that are still drawing up flushes, and then various dressing changes and standardization of dressing change kits. We mentioned about kind of environmental hygiene or environmental cleanliness, and that can impact a number of things, including linen changes, but also how often the room might be terminally cleaned, or other surfaces and how they're cleaned. So a linen change is one of the things that we'll be looking at. And as already mentioned, SPS is working with the CDC for looking at trends and changes in organisms during this time where rates were seen to increase. And then, have there been changes in patient population? We know that, I'm not sure about changes, but we do know that there are some targeted groups that contribute a high number of the CLABSI events. And so number one is hematology oncology. The hematology oncology units have more of the CLABSIs than any other unit, and NICU is not too far behind. So by adding those two units together, they usually make up just about half of all the CLABSIs that are seen within a hospital. So again, if we can focus on what's unique and different about those patient populations and start to get a little bit more data that is specific to those units, then that will give us some ability to help bring down the rates in those very high-risk units. So again, part of the reason for the HEMONC Special Interest Group, but even again, it is a lot about increasing our reliability. To this point in SPS, the reliability data that we see has been kind of hospital-wide for each center and then across the entire network. But we will be looking forward into 2016 into actually making some recommendations around really how we look at compliance and reliability, giving some tools to assist with that, really encouraging centers to look at all the units in their hospital when they're looking for reliability and measuring it, and then they will report it by those units so that we can narrow down on where there may be problems. Next slide. And then these, again, are some of the things that did not really seem to be huge factors in the special cause analysis. So changes in unit acuity for that period of time probably was no greater than it had been any other time, and hard to blame the increase in rates on that. I think the need for ongoing education, again, there certainly will be points of that we will look at kind of bundled into the previous topics that we talked about when it comes to how do we measure reliability, in what way can we do that, and how are we assuring that staff members are competent in carrying out the bundle. So there will be some renewed effort in that way. Organizational factors didn't seem to be an issue. There is a belief among some that BSIs are not preventable with bundle care interventions only. But there is a difference between preventable versus reducible, and reducing them down to what the minimum number is. We don't know what that number is, but we hear this a lot in hematology oncology because of the patients in bone marrow transplant, for example, who have such severely compromised immune systems and broken down mucosal barriers that a lot of the oncologists want to say that that this is always going to happen, and we're not going to make this go away. And to some degree that may be true, but it doesn't mean that all of the cases we see are related to that, and it doesn't mean it couldn't be reduced further. Staffing turnover and doing anything different with the bundle elements didn't really seem to be a problem. Next slide. So next steps and what do we do in 2016 going forward? Again, we want to renew our focus on bundle reliability, and we really want 90% compliance or reliability across all units in all the hospitals. And we believe if we can standardize the process and get it carried out reliably, we will see a fall in the CLABSI rates. We do know that there was an impact on the definition when in 2015 it became more difficult to declare an infection a secondary infection, which would have perhaps been declared that in 2014. So that did have some role when looking at special cause, but it did not take away the increase in rates entirely. Again, putting together some of these things that we've picked up from hospitals and reviewing the data and looking at processes, we've got some work groups for 2016 going forward. Again, one is a HEMOC population work group, and that will be kicking off here in the next couple of months. And there has been great interest among the neonatal group and the providers in the NICUs of wanting to do something similar, so we are looking at that as well. Again, we mentioned the device and products work group, and then we'll likely have another group that's really very, very much focused on reliability and process execution. Next slide.
Great.
So Emily, I think, is going to finish up with us.
Yep. Thanks so much, Jeff. So this is the open discussion section. So if you have questions or want to ask a question, we just ask that you type it in, into the chat box, and we'll work to unmute you. So I'm going to pause and let folks gather their thoughts to input into the question box. So while you're doing that, a couple of things. This session is being recorded and will be on our public website post webinar probably by Monday, along with a copy of the slides too. I know we got a couple of questions in the question box with regard to that. So Erin, could you take us to the slide? So just wanted to put out on our public website, there it is, solutionsforpatientsafety.org. Our operational definitions, our bundles, and our data is public and all on that site. So next slide, Erin. This is just showing how to get to the information that might be useful for your hospital. So you would click on the banner for hospitals. Next slide. As I stated, that's how you get to our operational definitions. Erin, if you click again, those are our recommended bundles that we have for our hospital-acquired condition, and then we do have some standard prevention bundles for some of our hospital-acquired conditions, as you can see, marked by number 3. Next slide, Erin. And as I alluded to, our results, our data, our aggregated data is on our website as well, which we're actually fairly proud of. So I think that's it in terms of my piece of it. And now we do have questions rolling in. So first up is Amalia Cotton, and I apologize if I mispronounce any names. So I know you had a question for the presenter. So why don't you go ahead? Can you hear us? Okay, maybe we're having some technical difficulties, and we'll move on to Ken Wing. Let me scroll down and see if I can get you unmuted, Ken.
Okay. Hi there. Thank you very much for this. Can you hear me?
Yes. Go ahead, Ken.
So I'm wondering, are you going to be sharing some data at some point about your tests of these special cause series?
So Mike and Jeff and Margie, I think, would agree that yes, we would be sharing, you know, some information with regard to what we have found.
Ken, this is Mike Gutzeit, and thanks, Emily, for starting us off on that, and certainly Margie or Jeff, feel free to jump in. As far as the time frame goes, I think it depends on what we find. One of the areas of focus has always been transparency with solutions for patient safety, and so I'm not sure if you are an SPS member hospital or not, because if you are, certainly the SharePoint site has lots of transparent information. But in terms of sharing some of the special cause analysis and special interest group results, we certainly would be happy to share that with others with the proper safeguards around it when we have more information. So maybe we could follow up offline and give you more specific timelines about that. I don't think I could give you specifics right now about it. Okay. Jeff or Margie, any additional information that would be helpful for Ken?
So I think you are right. It's really going to depend on each group. I think, you know, my intent with the reliability and Holly's intent with the products, and we're on different timelines, I think, and what our ultimate goal is. So, but definitely there will be results to share. I'm confident of that when we have them.
Thank you.
Great, thanks, Ken. The next question comes from Deb. Deb, I believe you had a question about the special work groups related to HEMONC. So, Matt, I'm not sure if Deb's unmuted or not.
This is Deb. Can you hear me?
Hey, Deb, go ahead.
So I missed a little bit of the beginning of this, and so you might have already said this. This is the HEMONC group that you were talking about at the very end of the presentation is different than the Children's Hospital Association CLABSI consortium, right?
It is different, but it is part of the transition of the inpatient work from CHA moving over. So after March, the Children's Hospital Association group will no longer be collecting data or working on inpatient CLABSI anymore. It will be strictly an ambulatory network. So there will be communication coming out very, very shortly, both to all of the current Children's Hospital Association collaborative members, but also to all interested units throughout the current SPS hospital to see who wants to be part of the special interest group. There has been about 15 or so that have already expressed an interest in doing that some time ago, and we've kind of kept them on hold till we have our plan in place. But we're really ready at this point with the different measures that we're going to collect and how we're going to do that. The communication is going out that you can sign up to be part of the special interest group. We'll gather together, do a series of calls and webinars to start looking at what we can do in our specific population. So it will be, I'm hoping that many of the hospitals that have been part of the CHA collaborative, there were about 29 still working on inpatient, and almost all of them were SPS hospitals. So I'm hoping they will move over into this special interest group, and we'll continue to pick up the data collection in April. And then we will also have new centers join us that, from SPS that were not previously part of the collaborative. There will be a survey. There will be a survey going out at the start of when we send out the communication, so that we can get a sense from each hospital like where you are on this journey, because there will be some that have been part of the CHA group for a long time and will be very knowledgeable about the process and the bundle and all of that. But then there'll be others that will probably be newer to this work, and we want to try to bring everybody up to one level of understanding as we move forward.
So many institutions will be in two different groups, essentially, an ambulatory and an inpatient.
That's correct. That's correct. Okay. Our hospital would be one of those. Yeah.
Thanks.
Great. Thank you. Next, we're going to try Amelia Cotton again with her question related to alcohol caps. So can you hear us now?
Yes, can you hear me?
Yes, great. And I think either Margie or Mike might be able to answer your question. So
okay. Why would alcohol caps be a suspected cause for infection? Defects, improper use?
So it probably ran the entire gambit. It was we put them in, our infection rate went up, so we took them out. We put them in, realized that it changed the way we had to hold the line or do something with the line. We think it's causing a problem, so we kept them in but did more education. There were a couple of hospitals who said, we put them in, our adult counterparts aren't having a problem with their infection rate. We are. We don't know if it's this, but and there's this feeling among some that when you put this cap on, the thought process changes to, oh, I don't have to scrub it anymore because that thing's on it. And were they still following the pieces of the bundle that did apply, to another access port that maybe didn't have a passive disinfectant cap on it? Lots of different things. There are some hospitals who put them on, love them. Their infection rate went down. They kept them on. It is really, truly across the board. And it's across all products. It's not just one. It seems to be every vendor as well.
So maybe it's caused kind of a false sense of security.
Right. Right.
Okay. Thank you very much.
Mm-hmm.
Thanks for the question.
The next question comes from Devara Wright. Are you able to hear us?
Hey, Em, this is Matt. It looks like Devara is not on the line with us,
okay.
So apologies for that.
Great, thanks. So I'm going to read the question on Devara's behalf, and I think, Margie, you'll be able to answer this. Is there any discussion about using chlorhexidine pads for scrubbing the hub prior to accessing the CVEL?
If you mean versus alcohol, our bundle is not that prescriptive. We give the option of using what your hospital uses as a product. Our bundle element states have a standard process for accessing the line and follow it explicitly. So we, in the parentheses, when you read the bundle, the care descriptor says alcohol scrub or ChlorPrep scrub. Now we do have hospitals that are trialing and using Prevantix, which is the 5-second scrub versus 15 versus 30. So yes, we have hospitals in the network using all of the above or any of the above. But the point of the bundle is pick one, be standard about it, and do it every time and do it correctly. I hope that helps.
Great. Thanks so much. Next, we'll go to Cynthia Laporte. And I think this is either any one of the three co-leaders can help answer that question. So Cynthia, you want to go ahead and ask?
Yeah, I just was curious about if any visiting hours have changed or ages of visitors have changed within the clinical environments.
That didn't come up. There wasn't a hospital that answered the survey that responded about visiting that I can remember.
Right. And just because
Yes,
more families... Oh, go ahead, sorry.
Go ahead. No, you finish. Go ahead.
Well, just the question about, we really want to have family-centered care, and when you have the entire family unit around, it's hard to monitor all that hand washing. So,
right.
And the lines do dangle. I do think that the tubing is really a critical piece of this, how long you keep it, and that, especially when the kids are a variety of size heights and trying to walk, etc. So I was just curious if the family was a concern.
Hey Cynthia, that's an interesting perspective, because as we were talking about the unique circumstances of children, obviously family-centered care is another unique aspect of that. And in the network for our CLABSI work, we have focused on family involvement primarily around educating families, involving them as partners, and asking them to call us out if we're not following the proper sequence of steps for the maintenance bundle and things like that. But the other side of the coin is, are there more factors related to the number of visitors and the potential touches? And again, kids are kids, and sometimes siblings become very interested in what's that thing dangling from your chest, and how do I fiddle with that a little bit. So, but Margie's correct. We, in kind of open forums where we've asked, are there any other concerns? We've not heard that one rise up as one that's an issue, but it's an interesting one to keep our eyes open for and keep our thoughts open to.
Mm-hmm. Yeah, thank you.
Great, thanks. The next person that we have up is Diane, with regard to her question around bundle compliance that I think you, Margie, might be able to answer. So Diane, can you hear us?
Yes, can you hear me?
Sure. Yeah.
Yes, my question is, when you were speaking of some of the goals of to increase the bundle compliance, are you advocating for observation of the bundle compliance versus auditing the documentation of the bundle compliance? Because we have noted a real discrepancy in the two, in that we have had fairly high compliance with the documentation, but when we are going out to do at the bedside auditing, is that the practice is all over the place.
Right. It's an excellent question, and it is one of the things that we are talking about with our reliability. Because we get reliability data from hospitals across the country, and we've never said do it this way. We've let all of our network hospitals collect the data as they did. That's why we're now thinking, are we sure we're getting the reliability that we really truly are experiencing? And so the purpose of the focus group will be to develop a tool to actually observe, and observation is always going to be your best way. We go around and around. My colleagues will tell you that it's a hot button with me, because if you're looking at documentation as your only method, it becomes documentation compliance versus actual bundle compliance.
Correct.
So when you can, I think what we're going to try is to advocate for, if you know you want to see accessing when you go in a unit, you know what time medications are being given, that's when you watch, versus just picking a time to go do your audits and asking a nurse, did you do these things before you access, actually watching them do it. So that's not as easy, and we know that. We certainly accept that. So kind of, you know, walking that fine line of making it cumbersome to do, but really needing some valid data and being able to say this really is what we're doing consistently. So
and we've discovered that that nurses, it's not that people believe that they are doing all the, when they're documenting, that they're covering all those steps, but the rigor and there's just great variability to the rigor and how the bundle steps are actually being done.
Absolutely. Absolutely. Thank you. That was great.
Thank you.
Great. I'm scrolling through the question box. Let me just double check. We don't have any more questions in the question box. I'll pause for a second to see if anyone has any other remaining questions.
Emily, while we're waiting, could I just add one thing to the discussion here, and it's an enhancement of what Jeff said during his portion of the presentation, and that is that, for those who've been involved in the CLABSI work for a number of years now, if you think back to where we were maybe 10 years ago, the discussion at that time was, well, we treat complex patients in complex environments and a amount of CLABSI is acceptable. And I think what we've seen is a shift in that perception, and Jeff highlighted it really well in his portion, is that why can't we strive for zero, and why can't we achieve zero? We may not get there, but we certainly should be looking to try and use that as the marker that we're using rather than an acceptable percentage of patients getting infection. So it's really shifted, and having transparency with data, sharing information is really important. And for those of you who've asked questions, I know that my colleagues Jeff and Margie and Holly would be happy to talk offline if you are struggling, or if you have specific questions, we would be happy to address them. You can get in touch with us through SPS.
Absolutely.
Emily, maybe you can put our contact information on the slides before they're posted.
Absolutely, that's a great idea. Thanks so much, Margie. Great, and with that, I think we're ready to wrap up, and I will hand it over to Anya Land.
Okay, hi everyone. Thanks so much for sitting in on our webinar today. Just want to give you a quick reminder that this is one of 4 webinars that Solutions for Patient Safety will share with you all this year. So feel free to reach out to us. We'd love to connect. You can always reach us by sending us an email at ochsps@cchmc.org, especially if you have any additional questions or if you have topics that you'd like us to cover on future webinars, please feel free. We're also on social media all the time, so you can reach us on Twitter at SPS4Kids, or you can always tweet about the work by hashtagging #ShareSafety. Also feel free to reach out to us on Facebook and like our page. After this webinar, I'll definitely update the PowerPoint and the recording and include our contact information if you have additional questions. And I'll end here with a quote. Margaret Mead once said, "Never believe that a few caring people can't change the world. For indeed, that's all who ever have." So thank you so much for taking time out of your Friday afternoon to sit in on our webinar. And please implement or share what you learned today so that we can continue to reach our goal of zero harm for kids around the U.S. Thank you so much.